Appreciate y'all coming out here today. I know it's a great day outside, and I think for you to give up half of it to spend it with us, so we really appreciate it. I want to thank the people at Pennington also for putting on this great event year after year. They always do a wonderful job. A little bit more about myself before I get started. I am from Baton Rouge. I moved around a whole bunch during my education and first part of my career, and then I've been back since about 1998 when my husband and family we moved back to be closer to our extended family. I've been with the lake since then, but recently my good friend and long-term colleague Jerry Johnson and I had the opportunity to open up the primary care for women clinic that's also lake affiliated. And we're just looking at a different vision of delivering primary care to women, and we think we're off to a good start. But women's health care has always been a focus of my career from the very beginning. So when they asked me to do this talk 6 months ago, I had to pick a topic and submit a title, and this is what I submitted. About 2 weeks after that, I got an email saying, we really think it should just be heart disease risk and prevention. Can't you just leave the sex, drugs, rock and roll thing off? And I said, but I just want an audience, you know. I gotta have a tagline. I want people to come to my talk. I've got competition. And I said, you know, I think our audience is sophisticated enough to understand that sex is gender differences, drugs, we're going to talk about tobacco and aspirin and things like that, and then rock and roll, you know, that's lifestyle stuff, diet and exercise. So they thought about it a little bit more and eventually approved it, and here we are. So I wanted to take a minute to talk about the scope of the problem. I mean, everybody's got a heart, or at least most of us do. And so we're all at risk for heart disease, and heart disease can be many things to many different people, but the focus of this talk is atherosclerotic heart disease, the heart disease that leads to blockages in your coronary arteries, heart attacks, stents, bypasses, that kind of stuff. Heart disease in women can affect women of all ages. There are gender differences though. Typically, heart disease hits women about a decade later on average than it affects men. When it does strike, the symptoms can be very different than in men. They can be vague, they're not always the crushing substernal chest pain, and therefore diagnosis can be delayed or sometimes missed. Unfortunately though, when a woman does have that first event, that heart attack or bypass, their rate of survival is quite a bit lower than the survival of men having their first event. We don't really understand why that is, but it's a clear difference, and we're trying to solve it. 43 million women in the United States have heart disease. That's a lot. That translates into a death about once in every 80 seconds. Over the age of 40, 90% of women have one or more risk factors. And 1 in 3 women in this country will die of heart disease. So you can look around the room, 30% of us are going to die of heart disease. That's a lot. To put a little bit of local flair on it, this compares the Louisiana statistics with the nation's statistics in both the percent of people with heart disease and the number of heart disease deaths. So the United States statistics are in gold and Louisiana is in purple. And you can see that we're leading significantly in both categories. This is a look at a national map of the risk of developing heart disease in the next 10 years. And this is in women specifically. The darker the color, the worse off you are. And you can see that the Southeast has a concentration of high-risk states. Lots of women are going to be getting heart disease in the next 10 years. I look at that as job security, but you know, I'm here to try to help y'all. And thank goodness for Alabama and Mississippi, so we don't lead this category single-handedly. This compares heart disease to cancer. I think as we get older, those are the two main concerns most people have. Heart disease or cancer. I feel like one of those two things is going to get me. The most important part of this slide is on the far right, the totals. Heart disease being in red and cancer deaths being in black. And that's total cancer deaths from all cancers. And you can see that heart disease trumps that total by a lot. So again, 1 in 3 women are going to die of heart disease. I use this figure when I talk to patients sometimes who don't want to take their blood pressure medicine or don't want to take their cholesterol medicine. And I tell them, you know, if you had cancer and I was trying to give you chemotherapy, you'd probably be willing to put up with some side effects because you want to get rid of your cancer. So it's really not any different when we're trying to treat heart disease and the risk factors that lead to it. If you don't do what you can to lower your risk of subsequent events or first events, you're really torpedoing your opportunities to survive this disease. So that brings me to the PG-13 part of my talk. To be true to my title, we're going to talk about sex just a little bit. Nothing too risque, I promise. Nothing that you won't see on the commercial break of any major sporting event on television, in fact. So sexual activity and heart disease, there has actually been some data on this and published in some pretty major medical journals. And we'll talk just a little bit about that. But to understand it, I think it also helps us understand other stuff that you hear in the media and how you should interpret some of those reports you see on the news and the somewhat fantastic claims that are made. You might recognize this slide as coming from a commercial that sells a product because you don't always know when the moment is right. This happy couple is at the beach, actually, in their bathtubs. I don't know about you, but I always bring my bathtub to the beach. And I have this up here to remind me that I'm going to talk about an article that was published in 2011 in JAMA, which is the Journal of the American Medical Association. That's a highly powered, well-respected journal. They published a study by some investigators that came out and claimed that sexual activity tripled your risk of heart attack. Now, you can imagine that grabs headlines, that sells magazines. JAMA's no different from the National Enquirer. They got to sell magazines too. Then the morning shows pick it up and they bring out experts and they talk about the same thing. And all of a sudden you've got at the water fountain, oh my God, sex increases the risk of heart attack. I'm taking my life in my own hands. I should not do that. Is it true? Well, to understand, they're not lying. The investigators were not lying when they reported their data. It's really just how it's interpreted. And then maybe they are a little enthusiastic about their interpretation of the data. It comes down to a term called relative risk, and that's important in understanding a lot of this stuff. So, does it increase your risk? No, not really. It turns out that sexual activity is about the same risk, or about the same effort as climbing a flight of stairs. For the average person, I'm not saying any of y'all are average, you're all, I'm sure, well above average, but for the average person, it's about the same exertion as climbing a flight of stairs. And you have to understand that for anybody just sitting in this room that's middle-aged, a risk factor or two, your risk of having a heart attack is about 1 in a million per hour. Just going through your life, about 1 in a million per hour. So when they say it triples your risk by having sexual activity, then your risk is all of a sudden 3 in a million per hour. So when you think about it that way, that's really minuscule and probably not enough to change anybody's habits in any way. So keep that in mind as we talk about other things and how it impacts risk. I like this slide because it focuses on the kind of stuff you hear just like that. It's kind of blown out of proportion or misrepresented. You know, you see this all the time. You turn on the morning shows and X can cause Y and Z. You know, red wine causes cancer in women that wear heels or just anything. I'm confused by it. I know everybody's got to be confused by it, and you just don't know what to believe. It's very frustrating. So for some of the subsequent things we're going to talk about today, I'll try to put it in a little bit of a perspective for you. Drugs is the next category. There are obviously lots of drugs that impact cardiovascular disease, both good and bad. I can't talk about them all, so I tried to pick a handful of them that most of us are familiar with, that you hear a lot about, and that impact the most number of people. And I found a really cool picture of a cigarette. And so we're going to start with that. Tobacco, I think everybody in here knows that smoking is bad. If you don't, I'll be the first one to tell you smoking is bad for you. If you smoke, you ought to quit. It increases your risk of heart disease, it increases your risk of lung disease, and it increases your risk of a whole bunch of different cancers. You ought to quit. Unfortunately, 20% of women in Louisiana smoke. I don't know how they afford it. It's expensive to buy a pack of cigarettes. It's going to add gobs to your medical bills as you go forward. But really the most important thing I wanted to point out on this slide is the risk. The risk of smoking is big. So let's say your normal risk is here, you smoke, your risk is up here. When you quit smoking, at least in terms of cardiovascular disease, your risk goes back to baseline within 1 to 2 years of quitting. So that's a big impact you can make on your risk of heart disease just by putting the cigarettes out. You can't say quite the same about your risk of lung disease with smoking. It doesn't ever quite go back to the baseline. But with heart disease, you can make a huge impact. The next thing I wanted to talk about is aspirin. It's been out for a very long time. Mothers at least used to give it to their children. Lots of people take aspirin for a long time. We in the medical profession recommended most people taking aspirin to prevent heart disease, but the thinking over the last few years has really changed quite a lot in this regard. And there's for a couple of reasons. It's no longer thought to be beneficial for average risk women to take it for heart disease prevention. And the reason is that when you look at groups of women who are at average risk, so average risk can be you can have high blood pressure, you can even have diabetes or cholesterol, as long as you haven't had heart disease, you haven't had a stroke or a bypass or a stent, you just have a few risk factors. And we treat all those women with a low dose aspirin every single day. Well, it turns out we had to treat about 2,000 women every day for a year to prevent one event, and that event would be, heart attacks or death from heart disease. So that's a lot of aspirin to get one benefit. And then when you look at the flip side of it, in that group of people that we treated, about 1 out of every 3,000 had a major bleeding event, a stroke, or bleed in their gut that required surgery, transfusion, or sometimes death. And so there was a little bit of benefit, but it didn't seem to be enough benefit in those people to outweigh the risk. Now, that is not true if you have had a heart attack, bypass, or stent. Those people clearly benefit from aspirin and ought to be on an aspirin unless there's some major reason not to be. And that group of people, you only have to treat about 50 of them to get a benefit. So 50 people that have had an event, treat with aspirin for a year, you will prevent a death. So that's a reasonable thing, and that should be done. So my point here is not really to make you change what you're doing, but because the issues are complex. But if what I'm saying makes you think, well, I'm taking it and maybe I shouldn't, or I'm not taking it and it sounds like I should, put it on your list and talk to your doctor next time you go in. This is an easy thing to overlook in a busy clinic appointment. I do it all the time. So if you bring it up, it'll at least allow you to have that discussion and make sure you're in the right group with aspirin. Statins, another widely known group of drugs. These drugs have been out since the 80s. I think we all have a love-hate relationship with them. And for the most part, doctors love them and patients tend to hate them. And I think there are lots of reasons for that, but primarily, it doesn't matter what your cholesterol is. It could be 300, it could be 400. It's not going to make you feel bad until you have an event. So when the doctor says, well, here I have a medicine for you to take every single day that's going to cost you money and might make you feel not so great, that's a hard pill to swallow, and it takes a lot of convincing. And from a physician's standpoint, the attractive part about it is we like to see those numbers get good. We like to see those numbers fit in the boxes, and statins make that happen for sure. And but we've also experienced changes in guidelines that it seems like a million times since they've been out on the market, but a lot of changes in guidelines. And the most recent was about a year ago. But finally, I think the guidelines are well placed. There's been some controversy, but I think they're on the right path. And the change was that they went from recommending certain statins for a specific number on your cholesterol profile to, no, let's look at the patient's risk. Let's give the therapy to the people that are at higher risk because they're the ones that are going to get the biggest benefit. And the people that are really at low risk, they don't really need this therapy. They do better with just diet and exercise. The controversy was where that risk line was drawn, and it was a little bit arbitrary. I think people a lot smarter than I am sat up in a room somewhere up north probably and hashed through the data and came up with that 7.5%. And a lot of people think it's too low, that it really ought to be 10%. If your 10-year risk of heart disease is 10% or higher, maybe you benefit from a statin. Probably if you sell statins, you think that number ought to be quite a bit lower and everybody should be on a statin. But again, to understand that a statin, when somebody takes a statin, it will lower their risk of heart disease by 20%. Again, doesn't matter who you are, doesn't matter what your cholesterol number is, it will lower your risk by about 20%. So if your risk is up here and you lower it by 20%, your absolute risk is pretty good. That's a pretty good risk reduction. But if your risk is this big and you lower it by 20%, that's peanuts, that's nothing. It's not worth taking it. And that's really where they're trying to get. So when you're looking at one individual patient, how do you decide? Well, there's an app on my phone that I plug in numbers, and it calculates each individual patient's 10-year risk. When they've had a lipid profile done, it asks for things like age, gender, race, do you smoke, do they have high blood pressure, and they ask for specifically what their blood pressure was that day, and do they have diabetes. And then it spits out that number. And if that number comes out greater than 7.5%, we have a statin conversation. And that's where we are. In terms of risk, there are other risks. The one that's gotten a lot of publicity lately is the diabetes thing, and it turns out that in people that take statins, about 1 in 100 develop diabetes that would not have otherwise gotten it had they not been taking the statins. That's been looked at in detail, and if you're choosing the right patients, if you're putting the higher risk patients on statins, it turns out that statin therapy trumps that risk. Even the people that 1 in 100 that get diabetes are still better off being on statin therapy than not. So. And I should say too, and most of that talk is about average risk people that have had events that have known heart disease, stent, bypass, et cetera. They have a much larger benefit and a clear benefit in statins, and it's not controversial at all. Kind of the same with aspirin. We have to weigh our risks and benefits more carefully in the low risk people that we're talking about prevention, but when we're talking about treatment, it's not controversial. The next group would be the postmenopausal hormone replacement group. Another class of medication that's gotten a lot of publicity over the years, lots of controversy. It's one that's near and dear to my heart because early in my career I was on the faculty at Wake Forest. And my chairman came to me and said, look, I'd really like you to write a textbook chapter for me for the textbook on geriatric medicine, and I'd like you to title it Healthcare Issues of Older Women. So I said, sure, what else can I say? And I look back at that chapter every now and then, and I'm humbled. This was in the late 90s, and a good part of that chapter I spent writing about how great hormones were for postmenopausal women, how every postmenopausal woman ought to be on estrogen because obviously they lived longer, they had less heart disease, they had less dementia, they had better skin, better hair, all this stuff. And then in about 2002, the results from Women's Health Initiative came out, which was a large randomized trial that really took the scientific community by surprise. And it sort of blew all that other stuff out of the water, and it showed that actually the opposite was true. It actually increased your risk of heart disease. It increased your risk of some cancers. It increased your risk of dementia in some cases. And so, we had a paradigm shift, and we no longer recommend hormone replacement for prevention of heart disease. It has some legitimate uses, but not here, and not nearly as many legitimate uses as we thought it had. So I thought I'd give you a little bit of a little look at the risk that it does have. So if you treat people with estrogen or hormone replacement, about 1 in 250 would have a heart attack that they wouldn't otherwise have. 1 in 200 have a stroke that they wouldn't have had otherwise. About 1 in 100 get a blood clot. But interestingly, though, there were no excess deaths. So it took you down, but it didn't take you out for whatever reason. The final drug that I'm going to give a little bit of time to is, I think most people would recognize this as a marijuana leaf. It's been in the national dialogue quite a lot lately, as you know, and so I thought we ought to see what I could find out about it. It's actually legal in a couple of states. It's quasi-legal in others where they're using it for medicinal purposes. So I think it would be interesting to know, if you're using it to help people, what harm could it be doing too? There are not very many trials done on marijuana use because it's illegal. And there are plenty of volunteers for them, but no trials. I found a little bit on the risk of heart attack, which, as you can see from the slide, is 4.8 times greater in the hour after smoking marijuana. And if you remember back to the sexual activity thing, the baseline risk is 1 in a million per hour, so now you're at 4.8 per million per hour. And sexual activity was 3 per million per hour. So, I mean, it's a minor increase in risk. But I think if you smoke marijuana and have sex, you're a goner. The next section is rock and roll, which is, we're talking about lifestyle impact on heart disease risk and prevention. And in my mind, there are really two major ones. Obesity and physical inactivity. These are obviously related in some ways, but they are separate, and I'm going to try to show you some ways that they are really, truly separate. Lifestyle risk, again with the local flavor, Louisiana in the purple and the United States averages in the gold. You can see obesity, we're winning, and in physical activity, we're losing. The only thing I would say about this is survey data, and 76% of people in the United States reported that they exercised somewhat regularly, and 70% of people in Louisiana reported that. I don't think that's true. I just really don't think that's true at all. Unless the exercise is holding the sandwich up. This is the prevalence of obesity in this country from the 1960s and projected up to to 2030. I think it's actually higher than what they have on the slide because they say in 2030 it's going to be 50% prevalence, but I think we're already above that, depending on where you look at your data. But anyway, it's a big problem and it's costing us billions. This is another way of looking at the trends. The map on the left is from 1990, which is the year I graduated from medical school. And we really weren't doing that bad at that time. 10 to 15% obesity really kind of nationwide. It was a much more even distribution. But when you fast forward a decade to 2000 on the right, we're starting to see a concentration of obesity in the Southeast, and we've increased the prevalence of obesity by 10 to 15% in that one decade. And when you go down to 2010, we've again increased another 10 or 15%, and we've got over 30% obesity in this region. So again, we've got to do something about it. This is a slide looking at how, in women, how obesity is linked to non-fatal heart attack and fatal heart disease. So body mass index, which is our measure of obesity, is on the x-axis and increases as you go right, and risk of death is on the y-axis and increases as you go up. So basically, as you get bigger, your risk of death increases. But to me, the interesting thing about this slide is we do consider body mass index 25 and under to be normal. And if you look at this slide, when you go from a body mass index of 21 to 25, which is all normal, you're doubling your risk. So even within that normal range, your risk increases as your weight goes up. And this is a cost estimate. This is in billions with a B dollars. In 2000, we were spending about $100 billion attributable to overweight and obesity. That's a lot of money to me. In 2020, we're going to spend over $400 billion. And if we don't right the ship, we're going to be spending over $900 billion by 2030. And I don't really know how our society can afford that. Even cigarette taxes, it's not going to pay for that. So obesity is the new cancer in some people's minds. There's some corporate responsibility, I think, with the big three fast food restaurants, but they're making you can see small changes in putting nutritional information at the point of order and that kind of thing. I think that really will make a difference. But a lot of it's personal responsibility. I mean, we all have to take it upon ourselves to educate ourselves and make the right choices. I told a story. My daughter and I were at a fast food restaurant not too long ago, not one of the big three, but we were the only ones in the restaurant, thankfully. But they were one that provided the nutritional information. First choice we made, 950 calories. We're like, no, we can't do that. Second choice we made had 2 days worth of sodium in one dish. We're like, can't do that. Now my daughter's rolling her eyes. The lady behind the counter is giving me the stink eye. And finally, we found something we could agree on, and we had dinner. But, you know, it was a teaching moment for me because nothing on the menu, none of the words were bad. There was nothing fried on any of the rejected items. You know, it had things that sounded good, but they're clearly not when you look at the details. And for my daughter, I think, and for all of our kids, it's a great opportunity to make them aware. You know, habits are made when you're young, both bad and good, and we should all take the opportunity to help them make the right choices. If we are what we eat, we ought to at least know what we're eating and get them kind of in the habit of learning about that. So, that being said, what can we do diet-wise that might make a difference? Well, the Mediterranean diet. There are all kinds of diets out there. I know that. That's another place where there's big money. Lots of people are being inundated. But this is a diet that really has some great, it's been studied, it's been well studied, and there is really some great data to support it. What is it? Well, you have to picture what you might eat if you were laying on the beach in Greece or Italy. That's what I'm talking about. But this is kind of a Mediterranean food pyramid. You'll notice that it's really quite different from what we eat. A lot of people like that bottom row. This is the breads and the pastas and the grains. And, you know, it should be whole wheat and you know, a good mix of different stuff. The next row, vegetables, fruits, beans, and nuts. And that is a huge portion of the Mediterranean diet. Olive oil gets a whole line to itself. It's very important. And cheese and yogurt. All of those things are going to be eaten on a daily basis in the Mediterranean diet. The next layer up are the things that you eat just a few times a week. Fish, poultry, eggs, and sweets. When I first started looking into it, I just sort of assumed that if I'm on the Mediterranean, I'm eating fish every day, but that's not really the case. It's just a few times a week. But probably the biggest difference between this diet and what most Americans eat is that top one, is the red meat. They only allow it a few times a month and in very small amounts. I mean, I know people, and there are probably some of you in here, that have red meat with every single meal. But that's the biggest difference. Now, how can I convince you that it makes a difference? Let's look at some data at the next slide. As I said, this diet has been studied. It has been studied in normal people, us, sitting in this room, people that have maybe a few risk factors for heart disease but have not had an event. It has also been studied in people that are on the cardiac floor at the hospital that have just had their first heart attack or they've just had a bypass. How was it studied? Well, they compared the Mediterranean diet. There are two different versions in the blue and the red. One was olive oil and one was more nut concentrated, but both Mediterranean, versus the control diet. Now the control diet in these studies was not the Cane's and Popeye's diet. It was the American Heart Association nutritious low-fat diet. So it's something that we would normally give to somebody on the heart floor. You know, this is what we would tell you to eat. But we compared the Mediterranean diet, I say we, I wasn't part of the study, but the Mediterranean diet was compared to that diet in people that have just had an event as well as in just normal people walking around every day. And both studies were very impressive. There was a clear benefit after 5 years of treatment in both the people with heart disease and then the people that were just trying to prevent heart disease. And it separated out very early. The yellow group, that's the higher risk of having an event or death. And then the red and yellow, you can see their risk is quite a bit lower, and it separates out early. So when you look at the numbers, like we were talking about before, you had to put, for all the people that had had a heart attack or a bypass or whatever that got put on the Mediterranean diet versus the control diet, you had to treat about 30 of them to save a life. That's not very many. So 1 out of every 30 people put on the Mediterranean diet versus the other benefited in a mortality sense. They saved a life, and they saved events also. And then for just the average people that hadn't had an event that were put on the Mediterranean diet, one of about every 60 people benefited. And that over a 5-year period of time, but that's way better than the benefits we were seeing with aspirin, where it was only 1 in 2,000 people that benefited. 1 in 60 benefit, and there's no side effects to the Mediterranean diet. There's not really any excess cost necessarily. It's just a whole paradigm shift in the way we think about how we eat. So that's my story about that. Hopefully it'll at least get you to think about how you're eating and what you're eating. The next section and the final major section of this talk is the X factor, which is exercise. I know you're all exercising regularly, so I'm preaching to the choir. So we'll go with that. This slide is loaded, but I really like it. It's from the Nurses' Health Study, so it's all women. It's the fitness, fatness, mortality slide, and I'll try to take you through it. The three main groups, there are 3 groups. There's normal weight, overweight, and obese. And obese in this study is a BMI greater than 30. And then within those 3 groups, we have different levels of physical activity. The purple bars, the tallest ones in all 3 groups, are the people that don't exercise. The middle one, they exercise some, 1 to 3 hours a week. And then the green bars are the good people. They're exercising a lot, not an unreasonable amount, 3.5 hours a week of exercise. And you can see that their risk of death in each group, the more you exercise, which you may move to the right in each group, your risk of death decreases. So the green bars are the lowest bars in each group. And if you take one color bar, let's take the purple bar, and you move across just on the purple bars in weight, you can see the risk increases with body mass index. So your risk of death increases as you get bigger within each physical group. But I think it's also interesting to look at the normal weight people. So the group on the left, the purple bar, these guys that are at 2.9, those are the normal weighted non-exercisers. So the couch potatoes that just happen to have good genes or whatever in their normal weight. And you compare them to the really big people on the far right, the obese people that are green, but they're obese, but they're exercising more than 3.5 hours a week. They're better off than the normal weight couch potatoes. I think that's really interesting. And that's where you separate physical activity and weight. So it's not just an either or thing. This is a little bit different way of looking at it. It's 2 different studies in women only, and just showing you, as you get more active, as you move through groups 1 to 5, you're more active, your risk of death decreases. And so the data has been reproducible in several different ways. Now let's talk about how it affects just years of life. And this is another slide similar to the first one that looks at different weight categories and different physical activity categories. And this is a little bit different. Here, the winners are these up here in the very corner here. These are normal weight people that exercise. They meet the exercise guidelines. The next group are the people that meet half the guidelines, and then the lighter bars are the inactive people. And so you can see a couple of things I think are interesting here. The normal weight group, that exercise, is about the same, or is the same, as the overweight group that exercises. And so overweight is those people that have body mass indexes from 25 to 30. That gives you a lot of leeway. There's a lot of weight in there. But really they're not losing any years of life for those people in that group if they're exercising, if they're doing what they're supposed to do. Conversely, if you fall into the worst group on here, that would be the severely obese, which is going to be a BMI greater than 35, and you're inactive, you're giving up about 8 years of your life that you would not otherwise give up. If you're normal weight and you do nothing but sit on the couch, you're giving up 5 years of life. And again, interestingly, the normal weight couch potatoes, these guys here that are giving up 5 years of life, are really about the same as the really, really obese people that are exercising. And in fact, they're just maybe a little bit better off again. So exercise can trump a lot of other risk. This is a different way of looking at it. This is life expectancy gains. This is not separated out by weight class, just strictly on exercise. So if you meet 100% of the guidelines, you're the second bar from the left, and you're adding a little over 3 years to your life expectancy by meeting those guidelines. If you double that, which isn't an unreasonable amount, that's exercising moderately, about 5 hours a week, you can add, over 4 years of life to your life expectancy. So I think that's obvious that, get moving or die sooner. I mean, it's true, it is. And then my favorite slide is this one. It's not that diabetes, heart disease, and obesity runs in your family, it's that nobody runs in your family. And the last, so to drive home this point, 1 in 3 women will die of heart disease. 1 in 31 die of breast cancer. And breast cancer is hugely important, don't misunderstand me. But when we talk about population risk and what impacts our population the most, you got to understand this relationship, and we need to educate women that they need to place at least as much worry in the heart disease category as they do in the breast cancer category. This slide's my second to last, and if you'll bear with me, it's a 2 or 3 minute video that'll give you a different perspective. I can stand up here and talk about statistics and all that, but you're going to hear from a woman who had an event and a little bit of an epiphany after it, and I think it gives a different impact to our topic.
I was extremely worried about breast cancer. I was not worried about heart disease. Heart disease wasn't even on the radar. Whoa, wait a minute. I'm 36 years old and I just got smacked with my mortality. It's a difficult pain to describe. People talk about that crushing feeling, like an elephant sitting on your chest, but it's so unfamiliar, it doesn't make sense. It's a pain I've never felt before, and I don't want to ever feel again. I smoked, I didn't get good sleep, I wasn't really exercising, I didn't really eat well, stress like 120% all day long. And it was all sort of an afterthought, because really my main thing was my career. The heart attack stopped me dead in my tracks. It's like the gig's up. You live in fear. You don't know which day will be your last. It was baby steps over hurdles every single day to live normal again. The first time I walked a block, I was so afraid. Women just need to wake up. Heart disease is the #1 killer of women. I know when women are listening to this, they're like, okay, yeah, sure. They need to know their numbers. They need to know their cholesterol. They need to know their history. They need to know their BMI. They need to watch their stress. I can remember laying in the hospital saying, I have got to do something about this. So I took my story to the airwaves. If what I've been through helps another woman see the light, then it makes it worth it. This is your mother, this is your grandmother, this is your sister, this is your daughter. To know that there are studies now underway gives me great relief. Somebody out there is looking. That's what matters most. Red dress to me means I'm not alone, and I've never been alone. And I want other women to know that they're not alone, because that red dress means we're all here, and we are fighting, and we're going to tackle this.
All right, and that's it. If y'all have any questions, I'd be happy to answer them.